everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. Again, this is Ayman Saad. It's my pleasure to introduce the moderator of the next session, Dr. Makadi, our guest. He is our colleague, a consultant of hematology in the King Faisal Specialist Hospital and Research Center in Medina. And Dr. Hanan Al-Khaldi, also our colleague in King Faisal Specialist Hospital and Research Center, a consultant in the Department of Hematology, Acute Leukemia Section. Thank you.
Assalamu alaikum. So it's my pleasure to introduce our first speaker for this heavy session. I will introduce Dr. Ahmad Alotaibi. So Dr. Ahmad Alotaibi, he comes in with a mix of flavor of experience between Canadian and American and Saudi in managing acute leukemia. He's a consultant acute leukemia at the Cancer Center of Excellence at King Faisal Specialist Hospital and Research Center in Riyadh. He's also the current program director of the Acute Leukemia Fellowship. He will try and let us know currently if precision can actually help us in reshaping choices for therapy in patients with acute myeloid leukemia. Dr. Ahmed, the mic and the podium is yours.
Assalamu alaikum. Good afternoon, everybody. Thank you, Dr. Muhammad, for the introduction, and thank you for the SOHO Scientific and Organizing Committee for giving me the chance to present for you today. Brief disclosure. AML, only one session today for AML. So AML is very complex, heterogeneous disease. So it's not a single disease. I will not spend time on the pathogenesis and pathology of AML, but you can see the number of mutations that being detected in AML patient, very extensive number of mutations, and not only in each patient will have one mutations. So one patient will have a couple of mutations, interact with each other, and to make it more difficult, you can see in this cohort of patients, 86% of patients, they will have more than two driver mutation. So it's not a single mutation that you can target and control, it's multiple driver mutation per one patient. And to make it more complex, the AML is dynamic disease. So when patient relapse, not only they could have resistance to the targeted mutation as the other hematological malignancy or other malignancy in general, they will have clonal evolution. So a new clone could appear. It could be a new clone, could be a small clone that was not there, was small there, and then gets selected with therapy, and then will expand, as you can see on the figure on your left side, on your right side. This patient started with very small TKD mutation, mainly was ITD mutation. Then with relapse, they had mainly ITD mutation and very less and very or undetectable ITD mutation. So very complex, heterogeneous, very dynamic disease. It's not a single disease. So the standard of care, the historical standard of care is one size fits all. It's no more applicable to AML patients. It's not a single disease, as we said. So with improvement on the understanding of the biology of the disease and the available of a test that is available in practice, we have the NGS that we can risk stratify our patient, we can follow the MRD, and the emergence of novel therapies, we can now move to a personalized treatment approach. So no more one size fits all for AML. So what has been accomplished for AML treatment as of now? You can see in this figure showing for you the approved medication, FDA approved medication since 2017. Maybe 12 or 13 medication has been approved since 2017 for AML for different indication in upfront and in relapse setting and in maintenance. So what's the next step? We are hope that we will have more medication to come, but the focus now is not only in developing medication, we need to learn how to combine these medications, how to sequence them, how to combine them from benefit point of view and from the side effect point of view, and what's the best timing? Shall we use them in relapse, in upfront? And can we stratify or intensify or de-escalate the treatment? Can we save some patients from intensive chemotherapy with this available novel agent? We need to incorporate the molecular, the MRD testing, and the immunological and genetic marker in our decision. And very important, we need to have applicable approach to our patient, to our population. So we have to have our own clinical data, our own real-world data from our own population. That's the main deficiency that we have now. And we are working on that. And recently we have started the Saudi AML group, and we are hope that we will integrate the epidemiology and the outcome from different centers from our country and to get more data from our population. So let's move quickly to get some management advices and advances in AML. We'll focus on FLT3 mutated AML, IDH1 and KMT2A rearrangement AML and NPM1. So let's start with FLT3. So you all know the FLT3 receptor. It is the tyrosine kinase receptor, intracellular receptor. When get mutated, it will continuously signaling a pathway for cell and enhance the proliferation. We have the ITD, which is the more common and more negative prognostic marker for AML. We have the TKD, and we have different FLT3 inhibitor in the market. Type 1, type 2, we have the old generation, more broad, more side effect, and the new generation, second generation, gilteritinib, quizartinib, more selective, more potent, and maybe less side effect. So what's our standard of care for FLT3 mutated AML? You all know that we now incorporate FLT3 inhibitor in our upfront fit patient based on the two landmark study, the Reshape trial, which looked for midostaurin versus placebo with 7+3 for young and fit patient. And the second one is the Quantum First trial, looks for quizartinib for young and fit patient. And both trials showed survival and disease control benefit for young and fit FLT3 ITD and TKD for the Reshape, and FLT3 ITD only for Quantum First for quizartinib. So this is our standard of care now. How can we move forward? So the next question now is not incorporating FLT3 or not. Can we select which FLT3? We cannot compare between two trials, but the question we have, if we use the more selective FLT3 inhibitor, is it better than using the old FLT3 inhibitor? And this is the pre-ECOG trials, which looked for gilteritinib versus midostaurin with 7+3 phase 2 trials. And you can see here the outcome. We have gilteritinib 90 patient, the midostaurin 87 patient, and the median age was 54 years old, and the range was 18 to 71, and 27% of patients was more than 60 years old. So a bit older patient, and the main target was looking for deeper response. So you can see the MRD for patient who accomplished composite CR was not different, 40 versus 47%. But the overall composite CR was better with gilteritinib compared to midostaurin. And also the MRD conversion, the patient who had MRD positive post-induction and then get MRD negative post-consolidation were more with gilteritinib compared to midostaurin. So maybe more selective FLT3 inhibitor maybe will add more benefit compared to the older FLT3 inhibitor. The longer follow-up is needed to assess for the survival benefit. And to have better answer for this question, which FLT3 to use, we have ongoing phase 3 trial, the HAVON 156 AML trial, looking again for gilteritinib versus midostaurin with 7+3 for young and fit patient. And the study is already closed in June 2023, 777 patients, and we are still waiting for the results. We may have better answer for this question. So the standard of care to add FLT3 upfront, is that enough? We know most of the FLT3 patient will proceed eventually for transplant, and we know that FLT3 ITD patient have higher risk of relapse post-transplant. So the question, shall we incorporate FLT3 inhibitor for post-transplant? And this is guide us for the question about the maintenance of FLT3 inhibitor post-transplant. So here is the Chinese phase 3 trials, which looked for post-transplant sorafenib versus placebo. And you can see that it's, the sorafenib had better cumulative incidence of relapse and better survival compared to placebo in post-transplant maintenance. The other phase 2 trial is the SORMAIN trials, which phase 2 trials randomized, looked again for sorafenib versus placebo in post-transplant maintenance. And you can see also the relapse-free survival was better with sorafenib compared to placebo. And also the overall survival is better with sorafenib mainly at 2 years. So sorafenib is currently our standard of care as maintenance for FLT3 mutated AML post-transplant. When we look deeper for SOR main trials, when we look for the MRD status, you can see the sorafenib maintenance had better outcome for FLT3 for MRD positive patient. You can see in your left side, the MRD negative, there was no significant benefit, but for MRD positive patient, there was significantly better if we use sorafenib maintenance. And this is aligned with the phase 3 trials, the MORPHO trials, which looked for gilteritinib, phase 3 randomized placebo, gilteritinib versus placebo in FLT3 ITD mutated post-transplant. The study did not reach the main target, which the relapse-free survival. There was no benefit for relapse-free survival for gilteritinib versus placebo. Numerically, there was better, but statistically was not significant. But when they looked for MRD, the MRD negative patient did not have any benefit from gilteritinib, but MRD positive had significant relapse-free survival benefit with gilteritinib compared to placebo. So sorafenib will be, the FLT3 inhibitor will be given upfront and in maintenance post-transplant, and maybe MRD post-transplant can guide us which patient to receive FLT3 inhibitor. Let's move now for older and fit patient. The standard of care is azacitidine, and we can look for VIALE-A trial, the FLT3 mutated patient on VIALE-A. This is selected FLT3 mutated patient. There is a response benefit if you add VIN to AZA compared to placebo, 66 compared to 30%, but there was no survival benefit. So the question, if we target the FLT3 mutated patient with gilteritinib with AZA compared to placebo, will there be a benefit? You can see here the phase 3 trial, and unfortunately there was no survival benefit if we add gilteritinib with AZA compared to AZA alone. There was CR benefit, but there was no survival benefit. The study was negative. So I will move fast because of the time. So we moved for FLT3 mutated AML for triplet. So we know that single agent will not be enough for AML in general. So how about if we incorporate the triplet AZA, VIN, and FLT3 inhibitors? This is the MD Anderson experience when they give HMA, VIN, and FLT3 inhibitor. The median age was 70 years old, so those were older patients. And you can see the composite CR was 93%. And after cycle 4, the patient had significant MRD negative. And the median overall, the median relapse-free survival was 29 months, and the median overall survival was 38 months. So impressive data for triplet. It's still on trial. We don't know exactly how to dose it. It's very myelosuppressive regimen. And this trial will answer for us how to use it and is there is a clearly benefit or not. This is the trial looks for AZA-VIN gilteritinib versus AZA-VIN placebo for FLT3 mutated AML. So we hope we'll get the result from this study. I will skip the relapse FLT3 mutated AML. The standard of care is to give them gilteritinib. So let's move for second subtype of AML, the AML with IDH1 mutated. So you know the mechanism of IDH enzyme. It's a Krebs cycle. When it gets mutated, will accumulate the oncogene, the 2-hydroxyglutamate, which will cause more hypermethylation and block differentiation. So the standard of care as of now is AZA-VIN. So if we looked for the IDH mutated subpopulation in the VIALE-A group, you can see adding VIN will have more CR benefit. The CR/CRi is 66% compared to AZA alone, 9%. The survival is 10 months compared to almost 2 months with AZA alone. So adding VIN to IDH1 mutated AML is helpful with better survival. But the question, how about if we add IDH1 inhibitor, the ivosidenib? So this is the landmark agile study, phase 3, ivosidenib with AZA compared to AZA placebo. And you can see there is survival benefit, significantly, like 29 months with AZA compared to AZA placebo. And there is also a CR benefit, 29 months with AZA-IVO. We cannot compare trial to trial, so shall we use AZA-VIN or AZA-IVO-AZA? So maybe the better question is, what if we add the triplet again? So how about HMA, IVO, and venetoclax as triplet for IDH1 mutated AML? So this is again the MD Anderson experience, 31 patient. The CRC, the composite CR is 86%. with Ivo-Aza was around 50%, with Aza-Ven was around 60%, so the composite CR is much better. And the median survival was not reached in IDH1 mutated AML with median follow-up of 27 months. This is triplets still under investigation and very heavy myelosuppression. And you can see here with subsequent cycles, they reduce the duration of venetoclax. So we have to be careful when we use the triplet either with FLT3 or with IDH1. So this is really promising combination. And to have better answer, this is ongoing clinical trials, the EVOLVE-1, which looked for ivosidenib-aza placebo compared to ivosidenib-aza and venetoclax, and we will hope we'll have better answer with this randomized trials and how to use the medication with the best dosing in this combination. So if the IDH worked for older unfit patients, so how about IDH inhibitor on young and fit patient? So this is a 7+3 ivosidenib as phase 1 trials. How about adding IDH to 7+3 in young and fit patient? So here you can see 60 patient. The median age was 63, a bit older patient. 30% of them, they have secondary and therapy-related AML. And you can see the CR is 68% and the flow MRD negative is 80%. So impressive result. And the median overall survival was not reached with median follow-up is 9.3 months. And it's very safe medication, and there was no dose-limited toxicity with adding Ivo to intensive chemotherapy. The ivosidenib was given as continuous. Also, to have a better answer, we need to have a phase 3 trial, and this is the ongoing HOVON phase 3 trials looking for Ivo or enasidenib with 7+3 in young and fit patient. Already completed enrollment, so we'll hope to have the result in 1 or 2 years, inshallah. The last AML subtypes is the KMT2 rearrangement AML and the NPM1. And you all know about the menin inhibitors, which is the new class of AML treatment that recently got approved. So KMT2 is the complex protein that's mainly enhance or maintain the expression of the HOX gene. The HOX gene is very important for hematopoietic cells. It's helped in the differentiation and morphogenesis. So the preclinical study showed when we have the HOX gene overexpression, this will cause the leukemia. And the menin is very important part for KMT2A to have the action. So the menin inhibitors will block the menin KMT2A protein interaction and will block the action of the KMT2A protein, the abnormal and the normal part. The NPM1 mutated AML, they need the KMT2A protein to have their leukohomogenesis. So we think by inhibiting the menin KMT2A protein, we will treat the KMT2A rearrangement AML and the NPM1 mutated AML. So what data we have so far for menin inhibitors? This is multiple menin inhibitors in clinical trials. We have the revumenib, we have the ziftomenib, we have the blixemenib, and the enzomenib. All of these trials is tested in heavily pretreated, relapse refractory AML, and you can see the overall response is good for this heavily treated patient, around 40 to 60%, maybe except ziftomenib in KMT2 rearrangement is only 17 and 11%, but this is really impressive in this very heavy treated population. The main side effect is differentiation syndrome and prolonged QT, mainly with revumenib. The other menin inhibitor have differentiation, but very less QT prolongation.
2 minutes.
So again, when we have single agent that showed activity, the next question, can we combine them? As we said, the AML is a very heterogeneous disease, very difficult to target one thing to get control of AML. So how about revumenib with AZA and venetoclax in relapse AML? So this is one trial which looked for that phase 1/2. And you can see here the CR, the overall response is 82%. This is a heavy pre-treated patient. And using the triplet, the overall response is 82, the CR is 39%. The MRD negativity with patient who achieved CR/CRh is 88%. So this is very promising result. Still, we don't have the survival outcome because of the short duration of follow-up. And another triplet regimen with other menin inhibitors, we have the ziftomenib with AZA-VEN, and you can see the NPM1, the overall survival is impressive, 68%, but the KMT2A rearrangement, as we saw with the single agent, it's only very mild, like 33%. The other is Bleximenib with AZA-VEN, also very impressive in the patient with heavy pre-treated relapse refractory AML. Same approach, how about if we bring this new medication in upfront setting, and this medication is moving very quickly, and now we have this trial looking for AZA-VEN with Revumenib in newly diagnosed AML with KMT2 rearrangement and NPM1 mutation. And you can see the median age was 70 years old, so this is older population, and 40% of them were above 75 years old. And you can see here the CR for the all patient was 67%, and the composite CR is 81. The number is very low for the KMT2A rearrangement, only 9 patients, but it's a very impressive result. And we have multiple ongoing trials looking for the triplet compared to placebo, this one with Revumenib, and this one with the Bleximenib, and this one with Ziftomenib. All is ongoing trial to answer this question. How about Revumenib with 7+3? So it's moving very quick for upfront setting. And this trial this is recently on the EHA looking for the 600 milligram with the 7+3. And you can see here the CR rate is 98% for newly diagnosed patients, 7+3 plus menin inhibitors, and significant MRD negativity, 68%, with no significant safety concern. Same thing, phase 7+3 with Bleximenib, and also very impressive result. And ongoing trial looking for 7+3 with menin inhibitors is ongoing, and this trial is planning to initiate soon. So in conclusion, so AML is not a single disease, so one size fits all is not applicable here, so we have to have personalized approach for each patient. Comprehensive molecular test is mandatory, so I think it's unfair to treat a patient with AML without knowing the molecular and mutation profile in upfront and in relapse setting, because the result will affect the outcome of the patient. Adding more agent is not always better, so we are not looking for more treatment. We have to know how to combine them, how to manage the toxicity, and this is something we're gonna learn with more clinical trial. The field is moving very quickly. As we saw, the menin inhibitor started as relapse refractory and now is tested with upfront. So we have to have our own strategy. We are now struggling to get the menin inhibitors in relapse patients, but soon in a couple of years, it will be the standard maybe for upfront patients. So we have to have our own strategy how to deal with this expensive medication, which is moving now to the early standard of care. And the last, but very important, is to have our own data, our own population data to know what's fit for our patient. And this is, we need more of our epidemiology and our clinical study. And I hope with the Saudi AML group, we'll have more results soon, inshallah. Thank you very much.